So the kidneys filter a lot of your plasma. They filter the entire plasma volume 60 times each day. The filtrate that's produced is plasma without the proteins, because those don't get filtered. If we peed all that out, we would have no fluids left. So throughout the course of the nephron, our filtrate is processed to reclaim a lot of the stuff that was filtered and not reclaim the stuff we don't want. Urine is only less than 1% of the total filtrate, and it contains metabolic wastes and a lot of the unneeded substances. So there's three major ways urine is formed: glomerular filtration, tubular reabsorption, tubular secretion. So with tubular reabsorption, stuff moves from the renal tubule, such as the proximal convoluted tubule, back into the blood, and it does that by moving into the peritubular capillaries. So tubular reabsorption sucks out or returns all the glucose and amino acids, most of the water and salt, and a lot of other components back to the blood. Tubular secretion is the movement of non-filtered stuff to the filtrate, so moving from the peritubular capillaries back from the peritubular capillaries back into the filtrate selectively. And here's a picture showing that. So filtration happens at the glomerulus. We form this bulk filtrate, and then a lot of stuff gets reabsorbed, and then selectively stuff gets secreted back into the filtrate. Glomerular filtration is driven by hydrostatic pressure, or the pressure of fluids against those capillary walls. The glomerulus is very permeable and it has a large surface area, and glomerular blood pressure is much higher than most other capillaries. Big molecules greater than 5 nanometers are not filtered, plasma proteins. And we usually end up with around 10 millimeters of mercury of net filtration pressure, although this can vary a little bit. So it's determined, we've done this math before, it's determined by the hydrostatic pressure in the glomerulus, and then two forces that oppose that. The colloid osmotic pressure of the blood, right here, the tendency of blood to want to suck solutes back in, and the capsular hydrostatic pressure, or the pressure of fluids in the capsule exerting pressure back on that membrane. And as you can see, to have filtration happen, glomerular hydrostatic pressure has to exceed blood colloid osmotic pressure and capsular hydrostatic pressure. Glomerular filtration rate. So this is the amount or volume of filtrate formed per minute by the kidneys. And it's a lot, 100 to 125 mils per minute. And it is definitely influenced by net filtration pressure and how permeable the membrane is. And also the surface area available for filtration. Glomerular filtration rate is controlled by two mechanisms, two types of mechanisms. So it's controlled by multiple mechanisms, but there's two main types: intrinsic controls and extrinsic controls. Intrinsic controls act locally within the kidney, and extrinsic controls are nervous and endocrine mechanisms that maintain overall blood pressure but still affect kidney function. So our intrinsic controls are basically maintain a constant glomerular filtration rate when mean arterial pressure is in this range. They might not be able to maintain a constant glomerular filtration rate if blood pressure is really low from a massive hemorrhage or extremely high. And we have two types of renal autoregulation or intrinsic control of glomerular filtration in the kidney. And that's the myogenic mechanism and the tubuloglomerular feedback mechanism, which is caused, the tubular glomerular feedback mechanism is caused by senses, a mechanism that senses changes in the juxtaglomerular apparatus. So renal autoregulation uses a myogenic control related to the degree of stretch of the afferent arteriole. And so if the blood pressure is high and the afferent arteriole at the nephron is being stretched, it tends, remember with smooth muscle, when it's stretched, tends to constrict. So it tends to constrict and help maintain normal glomerular filtration rate. And this protects glomeruli from being damaged by high blood pressure, because high blood pressure is a risk factor for renal failure and it can damage your glomeruli. And basically the opposite happens with low blood pressure to maintain a normal glomerular filtration rate. The tubuloglomerular feedback mechanism responds to the rate of filtrate flow in the tubules. So if you have low filtrate, if glomerular filtration rate increases, filtrate flow will go up and increase in the tubule. Filtrate concentration will then become high because you've speeded up how fast filtrate is flowing through the kidney, through the nephron, and there won't be time to reabsorb all that sodium chloride. So those macula densa cells in the ascending loop of the loop of Henle that are part of the juxtaglomerular apparatus respond to increased sodium chloride by releasing stuff that a compound that constricts the afferent arteriole, and this will then decrease glomerular filtration rate. And the opposite occurs if glomerular filtration rate decreases. So some extrinsic controls are the sympathetic nervous system. Normally, your renal blood vessels are dilated, and the tubular glomerular feedback mechanism and the myogenic control mechanisms prevail. Under stress, epinephrine and norepinephrine are released, and these can cause constriction of the afferent arterioles. This can trigger renin, but it also inhibits filtration, so it decreases glomerular filtration rate. We have hormonal control mechanisms that mainly control blood volume, but they're also triggered when the granular cells of the juxtaglomerular apparatus sense low blood pressure. So this should say renin right here. So renin is secreted by those granular cells, and it converts angiotensinogen, a plasma protein that's secreted by the liver, to angiotensin I. And then angiotensin I is converted in several tissues. One major one is the lungs by angiotensin converting enzyme to angiotensin II. And angiotensin II does a lot of things to regulate and increase blood volume and maintain blood pressure. You may have heard of drugs called ACE inhibitors. And ACE inhibitors is a drug that inhibits this enzyme, and so it's given to somebody with high blood pressure. It inhibits the conversion of angiotensin I to angiotensin II, so hopefully contributing to lower blood pressure in that person. It's a very common class of drug that's given to people with high blood pressure these days. So angiotensin does a lot of things. Overall, it causes an increase in systemic blood pressure and an increase of blood volume by increasing sodium reabsorption. So if you can remember that, you're good. So it does that by constricting arterial or smooth muscle. That increases total peripheral resistance, and mean arterial pressure then rises. It stimulates the reabsorption of sodium. It can directly do this in the renal tubule, and it also can do this by stimulating aldosterone. And if you remember, aldosterone causes the renal tubules and collecting duct to reabsorb more sodium. And then it can also stimulate the hypothalamus to release ADH, and ADH inserts water channels, aquaporins, into the collecting duct and causes more absorption of water. So angiotensin II can also decrease glomerular filtration rate. That's what these two things do. So it prevents more filtrate from being formed. It lowers the amount of filtrate being formed.